respected chairpersons. Thank you to Dr. Rajshekhar and Dr. Purohit for giving me this opportunity. My talk is on lipid lowering. How low is low enough? I think with the knowledge that today we have a lot of patients with atherosclerotic vascular disease, and our mortality and morbidity with this is increasing, and it's the leading cause of cardiovascular death and disability, especially in India. There's an extremely high odds of increased premature ischemic heart disease in India versus European countries. And in patients with established atherosclerotic vascular disease, you have a high risk of recurrent events. So you have an increased risk of recurrent MI, or increased risk of recurrent stroke. And the things that we can control are the modifiable risk factors. And amongst the modifiable risk factors that we have today is the value of the cholesterol, the value of cholesterol, the lipids basically. So long-term lipid reduction and long-term LDL reduction can help in reducing the lifetime risk of atherosclerotic vascular disease from 10% in the first year to almost 50 to 55% over a period of years. And this cumulative LDL goal in reducing the mortality and morbidity associated with atherosclerotic vascular disease is what helps us in monitoring these levels and in deciding what levels of LDL to maintain in these patients. If you look at all the well-established LDL cholesterol studies, most of them, and especially in type 2 diabetics, we are extremely high in the number of diabetics that we have, and it becomes extremely relevant today that a lot of our population of ASCVD are diabetics. We have robust clinical evidence on lipid lowering, but in spite of that, if you look at these charts, you realize that there is still a reasonable unmet need in terms of the value of LDL cholesterol that you need to reach. And even after lowering the LDL cholesterol to goal values or maximal tolerated statin therapy, you still have patients who have not met their goals of therapy. And these are in those trials which have used high-intensity statins. Even in those trials, you'll see that there are a fair amount of patients who do not achieve the LDL goals. So how low do you want it? How low is low? Low is less than 50, and if you calculate as very low, that's less than 20. So you have certain guidelines today which say and which help you in deciding what goals of therapy that you need to reach. If you look at the 2023 ESC guidelines, they say that you reduce the LDL cholesterol to less than 55. And if you have had a second cardiovascular event within 2 years, then you look at a goal of less than 40. The 2022 ACC guidelines recommend that you reduce it to less than 55. And you need a LDL cholesterol reduction of more than 50%. The Lipid Association of India in 2022 and the statement in 2023 have come out with a consensus update in 2023, which has classified into various groups. I can show you in the next few slides. But basically, they have an extreme cardiovascular risk category, where the goals of therapy go down to less than 50, less than 30. And extreme cardiovascular risk, which is category C, they also say that the LDL recommendation out to 10 to 15 milligrams percent is also acceptable. 2025 ACC AHA guidelines recommend that in those patients hospitalized with acute coronary syndromes, start off with high-intensity statins. And if you don't have, if your high-intensity statins don't work, add Ezetimibe or add another drug to reduce it, especially if your goal of therapy is less than 55, or you don't, your goal of therapy is less than 70, but you don't achieve those goals with the maximally tolerated dose of statins. In those patients who are intolerant to statins, you add a non-statin LDL cholesterol lowering therapy, reassess it after 4 to 8 weeks, and then decide what is the next form of therapy. This is an Indian real-world experience study, 575 patients, ACS with hyperlipidemia. What you realize is that we treat these patients, but do these patients achieve these goals? They don't. Most of them still remain with unacceptable levels of LDL values. Only about 21% of them will actually achieve what you set out to achieve in treating these patients. So in terms of the reason why unmet LDL needs are important. For every 1 millimole per liter increase in the LDL cholesterol values, you have a risk of, a higher risk of higher risk of MI, which is almost 30% higher than what the acceptable rate is. So you strike early, you strike strong. How do you do it? In the moment the patient has an ACS admission, start off with high intensity statins, and add Ezetimibe, which is an acceptable therapy. And today we have combination therapies available with us, where you can add a high-intensity statin along with an Ezetimibe. If you have a very high-risk patient, consider a PCSK9. And of course, you screen for hyperlipidemias, hypercholesterolemias. In those patients who are statin intolerant, you can always test them with another dose of statin or Ezetimibe, or you have the option of adding the PCSK9 or Bempedoic acid. The risk stratification algorithm by the Lipid Association of India takes into factors major ASCVD risk factors, other high risk factors, and moderate risk non-conventional risk factors, looking at even calcium scoring of 100 to 299 HUs, and then classify them into low risk, moderate risk, high risk, very high risk, and extreme risk category A and category B, which has been, this is the guidelines in 2022.